If a patient's at the end of their life and they are full comfort, they are a hospice patient, they don't want life-sustaining measures, they don't need oxygen. This has been studied. Our palliative folks at my hospital tell us this. It does not do anything that comforts them. If they are experiencing air hunger, if they are experiencing symptoms of anxiety because they are not getting enough oxygen, you can treat that medically with opiates or benzodiazepines. Providing oxygen in general will provide comfort visually to the family. And I think they are well-intentioned, right? Like they don't want their loved one to feel short of breath. They were just intubated or on a non-invasive or a high flow or a BiPAP or whatever. And it can be jarring to go from so much oxygen to nothing. But I think as long as they understand, of course, pre-medicate your patient. Don't just take something out without something to help with that transition, because that can produce suffering. The tactic I use is to, say to the patient, say to the family, we have the same goal here for the time that you still have left. You don't want that time to involve suffering. And although you might think, let's put a little blow-by oxygen or a little thing in the nasal cannula for comfort, that does not actually provide comfort. It can prolong the dying process. But here are some medications we can use preemptively to help with this transition. And here is our plan going forwards for nursing-driven or patient-driven analgesia, or whatever provider you have in the room. And I'm also very clear with, I don't know how long this process will take. It could take seconds, minutes, hours, or days. But the thing that I can guarantee is that the time that they still have left will be comfortable. I really think people in general don't want all the answers. They just want to be heard and to know that you have a plan and that you are aligned in your goals for the patient. People are not that complicated.